The main finding of our HOPE trial is that we find that the intravenous thrombolysis within 4.5 hours to 24 hours could increase the likely could still benefit in patients, in ischemic stroke patients who had the salvageable tissue identified from the perfusion imaging. So that means that it could support to extend the time window to 24 hours if the patient could identify with the criteria, with the imaging criteria. It is exciting because the previous recommendation for thrombolysis is within the 4.5-hour time window. Our trials find the results supporting to use the intravenous thrombolysis to 24 hours if the patient had the salvageable tissue identified from the CT perfusion imaging. So this is different. Of course, it could extend the time window and more patients could benefit from it, even though they previously has already lost the chance to be treated. Our trial actually is not the first trial to extend the time window to 24 hours because last year the TRACE-3 trials has also published the useful, the beneficial to treat the patient with ischemic plaques within 4.5 to 24 hours. But our trials is different from theirs because we also included patients who has not large vessel occlusions, because in TRACE-3 trial, they only enrolled the patient who has a large vessel occlusion. So this is a difference, and we also extend or expand the population, the patient population, so benefit from the treatment. We actually did the subgroup analysis from our trial, and we found that the treatment effect of outplace is more pronounced in patients who had the intracranial atherosclerosis, and also those patients who had a M1 segment of middle serval artery. So maybe for those specific situations, these patients could benefit more from the treatment. I think there might be 2 points to mention. First is the safety, about the safety outcome, because this is always more concerned by the clinicians. So in our studies, there's increase of the symptomatic intracranial hemorrhage, although the rate of the hemorrhage is different from the previous trial, but it does increase the rate of symptomatic intracranial hemorrhage. But we found that the rate of mortality is absolutely similar between the 2 groups. So that means that the increase of the symptomatic intracranial hemorrhage did not lead to the death within 19 days. So that means that to the clinicians, just do not be afraid of the hemorrhage when they use the thrombolysis, because the mortality, final mortality is the same. So would recommend to use the intracranial thrombolysis. So this is one point. And the second point from our trial, because as I mentioned, the difference between our trials and the previous TRACE-3 trial is that we also include the patient who suffered from median or distal vessel occlusion. So these patients were excluded in the TRACE-3 trial. So that means that we allow for a more inclusion of the patient population, and this was much more suitable for the treatment situation in the small stroke center, if they have no capability of the endovascular therapy. So they could just give the IVT instead of waiting to transfer to thrombectomy. So yeah, this is an expansion of the patient population. So these 2 points is what I want to focus on. I think the first question is that because this study was done in China, in Han Chinese population, so it might the population might be different from Western country. So although in the future we could extend our time window in Chinese patients, but we are not sure whether it could expand to other countries, other populations. It will still need further investigations. So I think in the future, it might be another trials to test such situation in different population. And another future question is it possible to extend the time window beyond 24 hours? That would be more exciting in the future.